Good afternoon, ladies and gentlemen, and welcome back to Design Thinking Ireland 2021, brought to you by Innovation Network. I'm delighted now to introduce our next speaker, Mr. Des O'Toole from the Health Service Executive, an organisation that has been looking after the country in such a superb way over the last 15, 16, 17 months. And Des is a clinical digital innovation lead and digital transformation lead at the Health Service Executive. And he has, for more than 35 years, been working in the health service, both across nursing roles and acute management and hospital inpatient inquiry. And Des is going to share with us his experience of using a human-centered approach to digital transformation within the Health Service Executive. Just two pointers, I suppose. We will have a Q&A session with Des at the end of his talk. So please type your questions into the Q&A tab at the bottom of the screen at any point during Des's talk. And also when Des is sharing his slides, if you want to adjust the relative size of the slide screen with the speaker screen, you can do that yourself individually by adjusting from the center. So Des, welcome to the IRDG conference. Great to have you here, and I'd hand over to you now.
Good afternoon, Dennis, and thanks very much for the generous invitation from yourself and Bernie to speak with you this afternoon. My name is Des O'Toole, and as Dennis has said, I am the clinical lead with digital transformation in the HSE. And I have a keen, you can move on to the next slide, please, Liam. I have keen interest in storytelling. And so today it would be just my slides will go through, I suppose, 4 distinct phases. So there's my story, a little piece about the digital transformation team, a little piece about the HSE response to COVID-19, a little piece about HSE and Respire Sense, and that's a device developed by a company called PMD in Cork, and how it went through a rapid innovation process during COVID-19. A keen interest in storytelling, as you know, and I'd just like to start and share with you a story. And I think, as you know that there's beauty, I suppose, in unexpected moments and the creation of a believable world that we can become immersed in. And for me, that has become the world of design thinking when I became introduced to it about 3 years ago. Because I had been exposed to science every day for 36 years. And yes, science helps to create and shape our world, but design thinking brought something else to it, and particularly in healthcare. And also with storytelling, now I'm exposed to a new world, which is, I suppose, a place of wonder for your soul, where your imagination becomes real. And storytelling and art bring all of this to life. This is a moment, when it all comes together, and the moment that we can all believe in. We're all hardwired for stories. We go on a mental journey that we can't resist. There's always conflict that touches our senses. We can see the flames, hear the crack of the embers, taste and smell the smoke. A blend of our senses is always present, which stimulates the release of different hormones in different scenarios. If it's experiencing a great TV show, like recently watching Line of Duty, that conflict and response are stimulated with the release of dopamine. Or your last pre-pandemic meal with loved ones or friends. Can you remember that? It's been a long time ago, but that would have been about laughter, relaxation, and joy, and endorphins were released then. Experiencing death and the loss of a loved one, or witnessing a close traumatic event, or even the death of somebody, is about empathy and trust and a bond and an association that you relate. And that's about with the release of oxytocin. And just the weekend before last, you may recall that, and I'm sure you've heard about Eriksson, who was playing for Denmark as they played Finland in the European Championships, and he collapsed on the field. And we wondered, oh, what's going on here? The guy went down, but due to the quick action of his teammates and his medical team, they initiated CPR, and they used an AED, or a defibrillator, to shock his heart back into life again and into a workable rhythm. And lots of people would have done, this is like an aha moment. And there are many times when there are aha moments in our lives. This is an aha moment for me and an aha moment for lots of people as well, because I'm involved in the local sports club near where I live. And you remember, you know, and if you're involved in a club or a society, so even if it's you're in the church choir, the bridge club, the rugby club, the hurling club, the GAA team, whatever it is, your local school, where you work, do you know where your AED is? Are the batteries in date? Are they out of date? Are the pads in it in date? Do I know how to use it? Do I know how to do CPR? Do I know how to do CPR in a COVID environment to keep myself safe and everybody else around me? And that prompted, and there's been multiple media stories about this, both TV, radio, print, social media, everything about this. And in fact, I'm delighted to see it. And hopefully that would be an aha moment for a lot of people to go and learn how to do CPR. It's not that difficult. I could teach you here now online, but we don't have the time to do that. But this blending of these elements helps to bring a story to life. Stories are the best way to cultivate trusting relationships. People feel connected. And may I share a story with you now? It's just a very brief story, but it's something that stuck with me. It was an aha moment for me, you know, a light bulb moment. For about 30 years ago, when I was a young nurse working in the emergency department in one of the Dublin hospitals. And I was working that day in the resuscitation room. And the red phone ring, just like the red phone rings in 24 hours in A&E or 999, what's your emergency? There's red phones in all of our hospitals as well. We got a call to say, from ambulance control, say that there was a 36-year-old lady en route to the hospital in a state of collapse, and that their ETA was about 7 to 8 minutes. So for us, just like you see in the TV show, we gather our team, we discuss what we're going to do. We prepare the room, prepare the trolley, prepare all of the monitoring equipment, prepare drugs, etc., and assign roles to various people for the duration of the resuscitation. So the lady arrived, and we knew that they told us that she had 3 young kids, which ranged in age from 4 to 14. And she had her husband, and they arrived also very soon afterwards. So we worked really hard, really hard, knowing that this is in the back of our minds, knowing that this could be any of us at any time. And our resuscitation attempts were unsuccessful. And sadly, that lady died. And days like that, you don't often remember, and you don't want to remember when you work in an emergency department. But sometimes things happen during them. And this was a particular spring day, actually. And I remember it really well. You know, the morning you get up at 7 a.m. So, God, another shift, you know, and you got to scrape the frost off the windscreen. You're walking on the grass and it crunches under your feet. And all you can see is a sea of white everywhere. That's the kind of day that was. And there were, you know, crocuses and snowdrops and daffodils all peeping into bloom as, you know, you look around. And I arrived into work, and that's the kind of day that it was. But then what happened was the lady's husband went to the relative's room with the medical staff, and he was being comforted, and people were talking to him and explaining about what had happened and what they tried to do. And I was asked to look after the children. And I said, okay, no problem at all. We went for a walk, and we went outside. And we talked about different things, about TV shows and friends and school and teachers and things like that. And we picked some flowers. And we brought the flowers back in. And meanwhile, my friends were preparing the little girl's mum for viewing. And we got some vase and containers, and we put the flowers into them. We went in, and the girls saw their mum, and we chatted and talked. And then the 4-year-old girl started to ask questions like, about death and dying, and what does dead mean? And I'll be honest with you, I was stuck. What can I say? How can I say this? How am I going to? And her 14-year-old sister interjected and said, look, Mom doesn't work anymore. She can't see you. Her eyes don't work anymore. She can't see you. Her ears don't work anymore. She can't hear you. She can't taste anything anymore. She doesn't work. And the 4-year-old kid got that. And straight away, I said, wow, like she was stepping into the role and assuming the role of her mom straight away and working with her sibling. And from that day to this, I remember that. And it's a day that will stay with me for the rest of my life. You know, it's a blending of these elements that helps to bring stories to life. Stories are the best way to cultivate trusting relationships. People feel connected. I've said that already, I'll say it again. So what I'd say is step outside your tiny little world, step inside the tiny little world of somebody else, and then do it again, and do it again, and do it again. And suddenly, all of these tiny little worlds, you know, they come together in this complex web and build a big complex world. And suddenly, without realizing it, you see the world differently. Everything has changed. And that's, of course, what this is about. Attend to other lives, other visions, listen to other people, enlighten yourselves. This is empathy. Next slide, please. So I work in digital transformation in the HSE and clinical lead there. And we have a vision. And that vision will take us, so you can see from the column on the left, from that paper-based solution that we work with at the moment, in predominantly in all hospitals across the country, actually, bar one and some of the maternity hospitals. So it's all paper-based. But we want to move on, and I'm not going to, you know, waste your time going through all of this, but we want to move to a traditional digital health model next, and then perhaps we move to a new digital health model. And our vision is that we would have this leapfrog strategy almost, where if we could avoid the middle piece, we jump straight into column number 3, where we would have home and community-based healthcare, where there would be remote monitoring for all people with long-term chronic illnesses, where there would be proactive and predictive health, where it's all cloud-based and open source, it's integrated, it's social, mobile, and it's AI-enabled, and all at a reduced cost. This is going to take time, but I hope that we could see this in our lifetime. Next slide, please. I work in the digital transformation team. We're a small team of 4 people. We wish at times that we were much bigger than what we are, but what we try to do is to help build a health system wide digital capability, capacity, and competence. Our digital health ecosystem vision is a rapid adoption of e-health technologies to support people's health journey, from hospitals to community and home, whilst improving the quality of living, the care provided, reducing costs, and enhancing the clinician experience. Now, we have 5 pillars in digital transformation, and they will be our digital academy. And our digital academy works through, we have offerings in basic data literacy and IT literacy, right up to a master's program that we run in UL. And it's based out of UL. And our first cohort actually just all received their results this week and have done some amazing projects over the duration of the last 2 years. And it's run out of UL, but it's actually delivered by the 8 universities across the country. And then we have open innovation. We have our digital labs, which is our innovation portfolio, our digital academy forum, which we hold quarterly, which we have eminent speakers give TED-type talks on what's happening in the world of digital health. And this is delivered to the broader healthcare ecosystem, both within the HSE, outside from industry and academia, and also patients as well. And then digital change and disruptive innovation, all underpinned by what we would say is that we want to inform, to ignite, to identify, to iterate, and to implement. Next slide, please. COVID, as you know, we've lived with it as a Big Bang disruptor. And Larry Downs has written a book called Big Bang Disruption. And if we look at this, and we look at what we would say is what the work that we do in digital transformation, where we have, look, there's innovators, early adopters, early majority, and you're familiar with Roger's change model here. And this is the kind of thing that we had. And we've experienced this here. COVID was a Big Bang disruptor. I just want to share you one example of the type of work that we were involved in right back at the very start. So next slide, please. So the Big Bang adoption within 48 hours. So yes, there was a system sitting in the background ready to go on e-prescribing. And you know that all of a sudden, when the first wave of COVID hit, that things wound down, that you couldn't go and visit your GP, that everything was virtual. So you couldn't pick up a prescription if you needed to pick up a prescription. And then there was also the issue about going to, and could you go to your pharmacy, or could you not go to your pharmacy, could you get your drugs, etc., etc. So there was a system in the background that was already there, but for various reasons, there were issues with the adoption of that system, and there were resistors, and like there is with every change process. But anyway, what happened was there were 2 statutory instruments signed by the then Minister for Health, Simon Harris, And on the 18th of April, there were 79 e-prescriptions in Ireland. On the 19th of April 2020, 298. And by the 20th of April, there was broad, widespread adoption of this system where there was 21,621 e-prescriptions on that day. So within 48 hours, this is the kind of big bang adoption. This is what COVID did, and we embraced it and moved with it. Next slide, please. So we talked a little bit about the HSE operational response to COVID-19. So I know, as we know it within the HSE, or the Integrated National Operational Hub, was established to provide oversight and governance to the operational support of service continuity in the COVID environment. Now, currently, this forum continues to be held on a weekly basis. But when COVID hit first, this forum met twice a day, 7 days a week, and everybody was continuously available to do whatever work was needed to be done. So the purpose of INO was to identify priorities for immediate response, engage the key stakeholders, whoever they happen to be, whatever area they happen to be in, and then to keep pace with evolving national public health advice, which would have dictated decisions that would be made at any time. Next slide, please. So, as you can see from this, if you look at the circle, you can see that, so INO are in the center, then with clinical advisors, then in the lighter blue, and then data information, which were driving the decisions. And then if we take, for example, if we look at the yellow or the orange circles at the top, so this is the tracing capacity that was stood up. So this was testing, contact tracing, and the laboratory system, and how we had to deal with that, and how to escalate and work with all of those people to get it, so we could test and trace all of this area. Then we have on the left in grey is acute capacity, and then on the right in red is community capacity, and how they worked together. So, for example, in community capacity was the opening of and the development of and the staffing of isolation centres, residential care, how we would look after residential care, community hubs, standing those up and running them, socially vulnerable people, for example, homeless people and people from different areas of society, and how we looked after them and how we could protect them from COVID. And then also our psychosocial services and how we worked with that. So to enable all of that, we had people in estates, in workforce or HR, telehealth, comms, procurement, and ICT. So they enabled everything else to go on. This is all the kind of work that went on in the background. And yes, we saw the TV documentaries from St. James's and from Tallaght, which showed frontline workers doing phenomenal, amazing work to look after the sick and look after all the people who had been admitted with COVID during that period. But in the background, all of this was going on all the time. So for 6 or 7 months, for example, that time I worked in procurement. No experience in procurement, and I have no desire to go back to procurement again either. But probably because that strict, rigid way of working with rules and directives and all that sort of stuff, it's just not my way of doing work. But having said that, they are an immensely driven, motivated and talented bunch of people, and the phenomenal work that they did during COVID and continue to do. For example, sourcing and procuring PPE, and then there's everything else, along and associated with all of that. I worked with a team where we stood up, so we had multiple offers coming in to the HSE, and we set up a portal and a standalone email address for all the offers that came in, and we between 6,000 and 7,000 offers came in. Yes, of course, you had all the usual stuff of people trying to sell you stuff, but you had people trying to give you stuff and to donate stuff as well. And that's what we had, with this whole piece about where there was this national interest where people wanted to work to make things better for Ireland. And we had lots of things coming. Like I was, multiple calls came in a day, but there was things like, get a call one day saying, Des, we want to give you 6,000 Easter eggs, do you want them? Will you take them? What will you do with them? So I said, well, what am I going to do with 6,000 Easter eggs? Where am I going to put them around? This sort of stuff, but look, we worked with the company, and that was Nestle. I think it's probably okay to work with Nestle, and Nestle gave us lots of stuff during the duration, but just caught us by surprise was the 6,000 Easter eggs. But anyway, what we did was, look, we decided that we would give these to the people in all of the contact tracing centres around the country, for them and for the people who worked with them, and also for their families as well, because they were working really hard 7 days a week, and we hadn't fully stood up all of that area to the full capacity. But in fairness to Nestle, they arranged the distribution and the delivery of 6,000 Easter eggs all over the country. But that's the type of thing that was going on in the background as well. There's multiple other things in terms of sourcing all sorts of medical equipment, etc., as well. So that was the operational response there. Next slide, please. So this is just to illustrate, and you probably can't see this, I'm not sure what this looks like on the screen, but this is the timeline of the integrated response. The first case of COVID-19 in Ireland was diagnosed on the 29th of February last year. And this just shows timeline and the number of cases, each one was there. And then it peaked then, in January of this year, where there was the highest number of daily confirmed cases. I can't remember, I think it was up about 8,000. But you can see there are various key moments there, different phases, different times that we went through, such as, when we opened self-isolation facilities, when the National Bereavement Support Line was established, the dates, all of those dates, so that this is all the kind of work that was going on in the background, right through to vaccinations and starting vaccination. The first vaccination in Ireland was given at the end of December. And then we know that up until April, that was like, we're well on target now to successfully vaccinate everybody who's entitled to a vaccine by September. So next slide, please. So the challenges of reintroducing service in a COVID environment, while at the same time being cognizant that a variant may come back and catch us unawares, or can it catch us unawares? So we have to be cautious all the time. And you well know, as well as I do, that there are plenty of cautious people out there that are keeping us safe all the time. But so the need to maintain what we would say is capacity for future COVID surge and additional impact, to plan for winter, because we have a surge every winter anyway, and while we would try to maintain capacity in acute hospitals should not exceed 80 to 85%, bearing in mind that we may need to use that, or we may not need to use that, but that the aim is to try to keep that free. Need to maintain COVID services for the foreseeable future. So what if something happens, in terms of testing, contact tracing, and our capacity to manage suspected or known COVID cases. Because we're living in a world where there's a naive global healthcare system. There's no experience in any healthcare system anywhere in the world to a pandemic of this scale or nature. There's limited evidence base and even experiential based knowledge. It just isn't there. So thankfully, we have some really good people working with us, both within the Department of Health and also within the HSE, who are and also around the academic institutions around the country as well, who've been keeping us very safe and doing a fine job since all of this started. So reduced capacity as a result of things like physical distancing measures, and if you're in a 6-bedded room in a hospital, that was reduced down to 4 beds to allow for physical distancing and things like that. So, and how tasks are done and how long they take due to PPE requirements, donning and doffing and all of that sort of stuff, is that the whole system changed and how people carried out their daily duties changed. Staffing challenges. Redeployment to COVID services, so people who weren't working, so some public health nurses or nurses who worked in operating theatres in hospital or in outpatient department would have been redeployed. So then there was the impact, staff testing, and if staff were routinely tested and then all of a sudden were confirmed positive, then they would go and their close contacts would go as well. What was the impact of that on staff? So there's lots of stuff going on in the background. And then to manage public expectations as well, and to increase positive health-seeking behaviours and clear, consistent messaging around the scale and scope of the service reintroduction. And I think that Irish people actually have been really cooperative with all of this. And I think the messaging has been clear. And I think the campaign from the very start, long after, when COVID is long gone, I'll still remember all of those yellow signs everywhere you go. And I've seen them everywhere. Outside shops and supermarkets and schools and churches and cemeteries and sport facilities, everywhere. Those yellow signs are everywhere. And I think we remember them long after they're gone. And hopefully we'll never do again. And the cost implications of the COVID environment, we won't even talk about that, because we know and that we will be paying for this for quite a long time yet. Next slide, please. So design and mobilisation for safe return of services. So leveraging valuable lessons learned from COVID response, one of our key enablers, building on new integrated ways of working to support service delivery, oversight balancing service return with the response to COVID surges, flexibility and governance of resources to rapidly respond to new plans and operational needs. So these are all the things that would be going on in the background. These would be the key enablers that we will work to restore safe return of services to the Irish population. Next slide, please. So safe return of services in a COVID-19 environment critical success factor really for us in critical success factor has been the integration of care pathways across acute and community services, rapid mobilisation of the principles of SLOSH care, so that's the right care to the right people at the right time in the right place. This is achieved by providing care to people close to their communities and close to their home and reducing hospital admissions. Now, this has been enabled through digitally enabled healthcare. There's been lots of stuff and lots of technology stood up. As you know, there was Attend Anywhere, there is Patient Empower, remote monitoring of patients, and there's another technology that I will share our story with in a few minutes, integrating care pathways across community and acute services. At early intervention, if someone is admitted to hospital, it's about intervening early with that patient in terms of social work, physiotherapy, occupational therapy, everything that goes along with all of that. And then linking in with community services as well. And service delivery focus, and this is really big. People will say there's red tape everywhere I go, every time I try to do something, is to try to enable services to deliver process light, to cut out on all the steps, to cut out all the process. Let's just make it happen. But at the same time, and you can see in the box on the right, we really have to be cognizant of and aware of the next variant, if there is one, and if we're not all vaccinated, we need to be so cautious of that, because we would need to be, to rapidly mobilize and stand up all of those services again that we had and continue to have, but not to the same scale across the country. Next slide, please. So we'll move on to this Respire Sense. Respire Sense is a device developed by a company in Cork, a small company in Cork called PMD Solutions, and led by and headed up by a chap called Miles Murray. And I've worked very closely with Miles since last year. And Miles developed, or invented even, it's an Irish invention, an automated respiratory rate monitoring tool. Now, I'll tell you quickly, because I know that a lot of our audience don't have clinical backgrounds and don't understand, but your respiratory rate is a key vital sign. It's often considered to be a forgotten vital sign. So when you talk about vital signs, you're talking about your pulse, temperature, blood pressure, and sometimes your oxygen saturation as well, and your respiratory rate. So if you breathe between 14 and 18 times a minute with an average of 16 times a minute, that everything else, as you know, when you go into a hospital, it's pretty much automated now. They do your blood pressure, they do your temperature, they do all sorts of things like this electronically and record them. But your respiratory rate still has to be calculated manually, so that someone stands at the end of your bed or stands at the side of your bed and they watch how many times your chest wall will rise and fall. And sometimes they will do that for a full minute or 30 seconds and multiply it by 2. Now, the risk with this is that a study was done last year in a large Irish hospital which showed that 81% of manually calculated respiratory rates were incorrect. So they were estimated too high, estimated too low, but weren't accurate there. Now, respiratory rate forms part of the Irish National Early Warnings System, or Early Warning Score System, INEWS. And it is, what happens is that each vital sign, when it is measured, is assigned a score. And when you tot up all those scores, if it goes beyond a certain number, that means that your condition has to be escalated. And then that will lead to clinical review by medical staff. So when we found, or not when we found, but when the researchers found that 80% of the manually, or 81% of the manually calculated respiratory rates were done, that meant that at least 40% of the early warning scores were incorrect. So how does Respire Sense help? Respire Sense can predict decline, allowing clinical teams time to implement escalations in a timely manner. For example, in Beaumont, where we piloted this first last year with, as a proof of concept, with Professor Richard Costello and Maura Rowland, who is the CNM2, and Richard, who was the respiratory consultant. It was shown to predict deterioration 12 hours earlier with over 90% sensitivity. So when patients experience hypoxic events, so hypoxia means that your oxygen saturation level drops below 92%. Usually most people in the audience would have an oxygen saturation level of 99 or 100%. And also pyrexia, where you would, or a temperature, a rise in your temperature, where you would have a temperature of 38 degrees or higher. Excuse me. Key vital sign in both early detection of deterioration and an integral part of the early warning score. So as I've said already, presently respiratory rate is manually counted. So as we know, so COVID-19 is a disease of the respiratory system and these patients are compromised. So Respire Sense is, will give significant insight into their status. We use that. So what does it look like in real life? You can see the picture of the lady on the edge of the screen there. So basically it's a device and it's worn on your abdominal wall, but just below your diaphragm. So it's motion sensitive. So it just picks up respiratory rate. It doesn't matter if you're walking or if you're eating or snoring or doing anything else. It excludes all of those. And it continually measures respiratory rate every 3 to 5 seconds. Next slide, please. So there we go. So that's what Respire Sense looks like. So there are 2 pieces to it. It's the Respire Sense sensor, which is disposable. And then there's the lobe you can see in the picture on the right. And the lobe is rechargeable, but the Respire Sense sensor is disposable. So it's rechargeable. The lobe is rechargeable, lasts for 5 to 7 days. And then that can be coupled then with the pulse oximeter, which will also give you oxygen saturation level and a pulse rate. So this is fed either via Bluetooth or it preferably fed via network. So a signal is sent from the lobe to a repeater, which goes up to the cloud and back down to the iPad on the nurse's desk, and essentially gives a reading, a continuous respiratory rate reading, and the parameters can be set for alarms for patients, for each individual patient as they're placed on the system. Now, next slide, please. Okay, so Respire Sense. I'll just tell you a little bit about PMD. That's when PMD was founded. Its aim was simple. They wanted to revolutionize respiratory outcomes by making every breath count. And this is their story so far. And we won't go through everything here, but basically, I've got to admire the resilience of Miles and his team. When they started to do this, they came across this idea, said, we could do this, we can do this. Back in 2011, this is 10 years ago. And right through, and if you look at, you know, what happened, you know, with 2015, getting the CE mark, 2017, clinical validation, part 1, part 2, clinical validation, 2018, 2019, phase 3 completed. So version 3 completed, and it's finalized and commercialized. 2020 arrives and Miles comes knocking on our door saying, look, guys, I have something that I think could help here. And would you be willing to help me do this? And we said, well, this is really good, proof of concept with this. And we went and worked with Richard Costello and Maura in Beaumont, tried it on COVID patients. And then this was the first 6 months of last year. And then for the second 6 months then of last year, then it was tried with non-COVID cohort patients. And this was in Cork, in University College Hospital in Cork, with Dr. Des Murphy, who's the National Respiratory Medicine lead. And it was quite successful up until things started to change in December time last year. So we still don't have all of the research done yet, because what happened then was wave 3 hit then in December, and it scuppered some of the work that we were doing. But look, we happily have all the data. We're working our way through that at the moment. It's just a bit stymied as a result of the next wave. So next slide, please. So what happened was we could see the value of this, and the clinicians involved and the nurses involved in this, the physiotherapists involved in this, could see the value of Respire Sense. So we put together a clinical and business case, which was presented to INO, and a decision was made at INO by the senior clinical staff. They're the clinical lead, Dr. Vida Hamilton, and Mr. Liam Woods, the lead for acute services, and various other INO team members, that we should go with this. We should roll this out across 26 acute hospitals and get to it, lads, I suppose is what they were saying to us. This was the second week in January. So we're saying, okay. So myself and Miles were the project leads. Where do we go? Where do we start? And we started with, you know, with contacting all of the hospitals. We had our vision, I suppose, where what we'd say was, what's our shared purpose in all of this? And we really needed to be and wanted to be, and this has got to be people-centered. And there are 2 key components to this. I suppose what we were saying was that our first piece was, yes, the installation of Respire Sense. Who do we need to get involved in this? So what we need are floor plans, the designated ward, where we're going to put the repeaters, do they need cabling, do they need this, etc., etc. So people who are dealing with were estates, clinical engineers, IT people to do all of that work. And then that was the installation piece. And the next piece then was the implementation piece. And the implementation piece is about, and I think, and just one second now, I'll find what was that. Phil yesterday, actually, just had a note there behind me, but Phil yesterday from IBM talked about magic people. And how do you identify magic people in IBM? And he seemed to have plenty of time to do it, and they had the methodology to do it and all that sort of stuff, and that's good. And I'd be familiar with, you know, that kind of stuff. But we didn't have time to do this social network analysis where we're going to find the right part. But what we were trying to do was use our gut, talk to the people there. But what we needed to find was that well-connected, influential person in that hospital. Because what we felt was that if we could engage with that well-connected, influential person, they would go and talk to their peers about this. And then we would have this peer-to-peer influence about the adoption of Respire Sense, the value of it, the use of it. And then that would lead to what we were calling multiplication, where there would be this broad spread, and all of a sudden then everybody wants this. And this is what we felt. This is what we were trying to do in 26 hospitals, you know. But look, we worked there. There was lots of work to be done. Like we did have, you know, we do have in the background, we have a clinical governance group that meets once a week. When we started first, we met every morning. 9:30 was our national implementation team. Then we had a steering group meeting at 10:30 where we all had key players with that. And once a week, we had our clinical governance and another steering group meeting as well, high-level steering group meeting. So we worked really hard with lots of people and lots of hospitals around the country to get this done, get it worked. And it has been a phenomenal success. Next slide, please. So all of the time, and I suppose, and you all in the audience, you're very familiar with this, but this is design thinking double diamond. And I just feel I just had to put this in just to pay tribute to the guys in PMD, because for them, for the last 10 years, they have been discovering, defining, developing, and delivering, and have been developing prototype after prototype and going through multiple iterative processes to refine this product, all down in Cork. And now it's been rolled out, a global first, an Irish invention, a global first, introduced in Ireland, and that I would say, I have no doubt that there will be global success with this device for PMD. Next slide, please. So this is where we are. So HSE and Respire Sense implementation. HSE was the first national healthcare system in the world to introduce standardized early warning system in all adult acute hospitals. And then HSE as the first national healthcare system in the world to address the clinical need to accurately measure respiratory rate in an acute hospital setting. Rapidly introducing the device, COVID-19 pandemic. We started in January and we're still going to roll it out across 26 hospitals in Ireland. We were going really, really well. As you can see, Respire Sense installed and up and running, and staff training going in the dark green hospitals, the lighter green hospitals, Respire Sense installation ongoing, and then bang, we were visited on the 13th of May by the cyber attack, which put pay to all this. Now, having said that, hospitals have continued in the background to continue with their preparation work and installation work if they can, but there's all sorts of issues now with networking and IP addresses and firewalls and things like that we won't be able to do until we're finished with all of this. But having said that, hospitals can and are continuing to function using Respire Sense in Bluetooth mode. And then there's just there's four yellow hospitals there that we have engaged with the hospitals, but just we haven't got to the same degree of involvement with them as we have with the other hospitals yet. But that's just the way, just working through the project plan. So next slide, please. So perfection is the enemy of the good when it comes to emergency management. Speed trumps perfection. The problem we have in society at the moment is that everyone is afraid of making a mistake. Everyone is afraid of the consequence of error. But the greatest error is not to move. The greatest error is to be paralyzed. by the fear of failure. And that's by a good, sound, solid man from Ireland, Mike Ryan, who's the Executive Director of World Health Organization, Health Emergencies Programme, and who we have all become very familiar with in the last 12 months. Next slide, please. Thank you very much for your time.
Thank you, Des. Thanks for a super presentation and giving us some insights into what's going on in the background. Much of this is not, I think, visible to us, the public. And look, before we get into the questions, I think I should pay a compliment to you, and all your colleagues in the HSE for the work you've done over the last 15, 16, 17 months for us, the public. I think the flexibility and the hard work and the protection you've provided is just, it's a debt, I think, that we find hard to repay. But look, thank you on behalf of everybody. So look, for the audience, please type in your questions into the Q&A box for Des, and we'll get to put those. There was a question in the chat, Des, from Deirdre, just to ask you this first. Deirdre says, thanks for your presentation. Des, very interesting. The value of storytelling in driving patient safety and quality improvement in the health service cannot be underestimated. The ethos of patient advocacy bodies is nothing without us, nothing about us without us. That is, nothing should be designed, planned, developed or delivered in the health service unless patients and service users have been centrally involved in that design. A couple of questions. She asks, how are patients and service users involved in the work of the digital transformation group? That's question one. And second question, what are the challenges experienced in the health service in ensuring those voices and experiences are heard and acted upon?
Okay, so what we would try to do is, and I suppose this is part of the role, and I've just been working in digital transformation in July, is to introduce or to bring that patient voice to digital transformation, which I insist on doing in everything that we do. And actually Deirdre there mentioned in her comments about QI, and what I try to do is, for me, is to merge QI and design thinking, because what the piece that was missing, or the piece that is missing from the QI piece, is to marry QI and design thinking, because the piece for me that was missing for many, many years is the empathy mapping piece, and how you can engage and how you can do that empathy mapping piece, and how you can, because it's a skill to be able to do that and to be able to work through that whole empathy mapping piece with the people who benefit from the service. And that so for example, so that's what we would do, and that's what we would hope to do. There is, for example, on our Digital Academy forum, we would always have a patient story during the as one of the key presentations, and patients would share their experience of their encounters with digital health. For example, our last staff had a gentleman who'd just been, and I can't remember the particular. It's basically it's a Medtronic electronic pancreas, and he's type 1 diabetes, very brittle diabetic, ended up in hospital 2, 3, 4 times a year, but now doesn't need. But he shared his story of all of that, with how this is engaged, or how this has changed his life for him. So yes, it is something that I suppose that we aspire to do, that we want to do, and we want to do more of, and that we're ensuring that we try to do that. Yeah. Okay. The second question, I can't remember what.
It was about the challenges. What are the challenges experienced in the health service in ensuring those voices, the patients and the service users, those voices and experiences are heard and acted upon?
Yeah, it's a big challenge, and it is, and there is a survey that's done of all service users, every 2 years, and that there would be feedback taken from that, but as with all surveys like that, is that maybe you don't always we usually get maybe the good news story. You don't get, I suppose when people are aggrieved or people are upset by something, and that's something that we would need to work harder on. But there are challenges with that. But I suppose to address that, I think that we in digital transformation would hope to integrate that and to integrate, the design thinking principles into the work that we do to ensure that we can make our contribution in that area.
Great. Thanks, Des. We have lots of questions here, so we'll try and get through them. There's one from Claudia. The HSE digital services are accessed through online forms, which could be a strategy to make those forms accessible and easy to use for citizens with low levels of digital literacy. So I suppose the question is, digital is great for lots of people, but some people have low levels of digital literacy and low bandwidth. Any comment on that?
No, I agree. It's not necessarily that. I agree. I take on board anything that's said, and I see myself. You can't see that, but I wear 2 hearing aids. I'm very, very hard of hearing. I really struggle with it. And for me, so some of the face-to-face digital platforms that were put up, like Attend Anywhere and places like that, didn't have, and still don't have, text on the bottom of the screen. There's a response to text auto cues and things like that there. And that for me and for people in my community or in the hard of hearing and deaf community was extremely challenging. It still is extremely challenging. And that's hopefully something that will be addressed. But no, I agree that we do need to be cognizant of that. And that's where I suppose that whole empathy piece and that service user piece comes into play. Yeah.
Great. Thanks, Des. Question here from Coco Pitzer. Excellent presentation. Thank you so much. How do you do the governance of these services and processes?
Okay, so there is governance around that. So there is a governance group that we work with. So we have, so we have the Chief Medical Information Officer, Chief Nursing Information Officer. We have what's called Digital Solutions Review Board. So there's a governance element built into that. Also, and everything that comes across, I suppose, our desk per se goes through that process of where, a pitch is made to us, then we take it away and we review it and see, is it something that we could work with? And then it would go to what's called the Digital Solutions Review Board, and that they would determine that, and that would be the governance that we would have around all of that. Yeah.
Excellent, great. Thanks, Des. Just I suppose a complimentary note there from Hilary. Amazing work, well done to all involved. Huge and valuable insights shared. Thank you. So I think that echoes everybody's sentiments. Des. Question from Maria. Thank you. Very interesting. What's ahead or envisaged for the next 3 to 5 years for the HSE? I suppose the patient focus, the digital transformation.
So for us within that digital space is that we want to continue to promote, and we want to build on offerings that I suppose came to the fore. And if I was to show you a funnel of what we had before COVID and what we have now and after COVID, and we now have a portfolio, for example, within digital transformation of up to 40 different projects that we're working on, whereas before COVID, we had a handful, 6 or 7, whereas COVID has brought on a lot, and it's provided an opportunity for lots of people like Respire Sense and PMG to get that, or like Patient Empower and people like that. There are lots of areas that we're working in. As you see, one of the very first slides I showed you was like, we could get that's that integration, with Sláinte Care, right patient, right place at the right time, all of that stay left, shift left philosophy that we have, and how can we work to build on that. And I think that we will make, as a result, we've learned a lot during COVID, and hopefully we can continue to sustain that and build on it, and that we don't revert back to the old ways of where we become comfortable. For example, of when we switch off the red eye blue zinc application or Attend Anywhere, and people have got to go back now and attend hospitals again. There's 40 or 50 people in an outpatient clinic, and everything is stored and written into manual paper charts and things like that. Whereas if there's something that we could do with, there's lots of things we're working on. For example, we're working with a company who we are ready to go, but now the cyber attack has interfered with a lot of the stuff that we were just about to launch. But this will be a PROMS based app. So this is just to illustrate with an example. Excuse me. So PROMS are patient reported outcome measures. So this was in people with chronic illness. we've tested and piloted this with one cohort of patients, with people with chronic renal disease from St. James's, but the next step for us was to do patients with musculoskeletal and rheumatoid disease, to do this in St. James's, or sorry, not in St. Vincent's and Tala, where patients who are on, they may be on what they call biologics, or very expensive long-term drugs, but they might only see the consultant every 3 months or every 6 months, but that the benefit the app would bring is that the patient can enter 2 or 3 times a week their symptoms, how they are, how they're feeling, etc., all of that, so that when they do attend the clinic, be it virtual or in person, is that all of the data and everything that they're fed into that, is that the doctor that they're seeing can access that and see how they have really been over the last 3 months or 6 months or whatever it is. Yeah. And that's in lots of areas, that we're looking at, chronic kidney disease, hematology, rheumatology, and also, working with developing, apps for patients with cancer, all of the sort of virtual stuff. So that kind of thing is going on there. The name of the company is My Patient Space, and we're doing a lot of good work with them. So hopefully when the cyber attack settles and then we're back to some sense of normality, is that we get that up and running. And that's we've been through a proof of concept with them, so we're now moving on to testing this and adopting this across the system.
Just one question, Des, in relation to cyber security. Obviously you've had the attack, but as you move more and more towards these digital solutions, are they more vulnerable towards then cyber attacks in the future? So on the one hand, it brings great benefits, but then on the other hand, does it leave us open to these attacks?
Now, okay, the first thing I'd say is I'm probably not the person to be talking to about this, because given my background as nursing and clinical, I would default to Martin or Ross always on something like this. But I know that the conversations go on in the background, that, for example, My Patient Space is managed by them, and they have their own cloud access, and it doesn't link in directly, and they're very happy. So for them, they would have been through a whole DPIA process with us in terms of security and security questionnaires and things like that, about where the data is stored, where it's stored, who has access to it, and that it wouldn't necessarily be linking into hospital systems or anything like that. Now, I'm not sure, is it more vulnerable or not? I don't know. I don't think so, is, I suppose, the answer, just from the meetings I'm attending, the conversations that I'm hearing.
I guess it's going to be part of that whole conversation.
Yeah.
Cybersecurity in the health service. Question here from Aileen, Des. Will the HSE continue with the Big Bang approach and just do it attitude, as it is necessary?
I hope so.
So can that be sustained? That sense of immediacy and emergency and moving quickly.
And I suppose that probably, that's a good question, Aileen, and thanks for that. It prompts lots of questions. Like, I would say that the Big Bang approach that we did with Respire Senses, lads, get stuck in and do this and roll this out across 26 hospitals as soon as you can. There's a huge amount of work on that. These kind of projects, usually with new technology, and this physical infrastructure has to be, changed and altered within each individual hospital in terms of cabling and that sort of stuff. Like something like this can usually takes about 2 to 3 years. There's red tape all over the place. There's issues with, security and procurement and all sorts of things like that. And COVID has allowed us to do that. Now, we don't have to go back to the old ways, and I hope we don't, is that it's process light, as I alluded to in one of the slides. I would like to think that we could, if we can see the value of something, that we should be allowed to do it. Now, having said that, it's exciting time, and it goes like, would I go through the last 6 months again? I probably would, like there were times when it was, back at the start when it was 7 days a week, and we were working really hard to do whatever. And we're not there yet, because this Respire Sense, we've got to think the implications of something like Respire Sense, that this is a game changer for how patients are managed and monitored, and how we manage the deteriorating patient and things like that. There's huge clinical implications for this across the country. And we're working really hard with, the early warning score people, and they're part of our steering group, and they work with us, and we have weekly webinars with, all the hospitals join in, and we, present case studies and talk about issues and challenges that they may be having with Respire Sense. So look, this is something, so for example, Respire Sense, yes, it was it was that big bang disruptor, but it did happen and it was innovative. Would we do it again? Yeah, I think so. Should we continue to do it? Yes, I think we should. I think we should. Yeah.
Okay. Thanks, Des. Technical question here from John. Can the device, the Respire Sense, be used to remote monitor or remote support for patients at home?
Sure. So what our plan is, we will get this up and running in hospitals first and get it running, get people familiar with and get used to it. But yes, because it's Bluetooth enabled, and then it can be app and link into an app. So when the person is at home, absolutely. So our plan would be to do this in hospital. We have already been approached by a couple of people who would have very dynamic respiratory outreach teams in hospitals around the country who are very keen to take it on, and we're kind of just saying, stall just for a moment, give us a few months to get sorted out. But yes, there's absolutely no doubt about that. Yeah, absolutely.
Great. Another complimentary comment there from Claudia. So thank you, Claudia. Couple of last questions before we finish up. George, again, he says he knows Miles from Respire Sense from 2012. Originally had great difficulty trying to get traction with the HSE. Obviously, that all changed. Is there a mechanism where startup medical products could engage with the HSE?
Yeah, and that would
with your team. Yeah.
Yeah, and that's through our team, with us, and we have a website. It's HSE Digital Transformation, or we're on Twitter or any of that. Contact us. Absolutely. Yeah. And
Brilliant.
we'll be more than happy. We will be more than happy to engage with you, set up a call, discuss, demonstrate, do whatever we. Yeah, absolutely. We see we need to be. We're more than happy to. We wouldn't say no to anybody. So initially, no.
Fantastic. And Aileen, I suppose a related question. How can we keep up to date? So I think you taught us that it is okay not to know. Go ask and ask again, be curious and then create. Thank you for your story. So another good question. I think we had a question there saying maybe how do we keep up to date with developments? I think you have a quarterly webinar, is it? Quarterly. You might tell people about that, Des.
Okay, so keep up to date with what's happening, what's going on. So we have Twitter, follow us and we'll follow you back. And it's a follow for follow, as the kids say. We have our website, and we also have a quarterly Digital Academy Forum. So this will be industry leaders. So this will be across lots of areas that we would have, and we would have people from. So for example, last time round, we had somebody from IBM talked about opportunities for blockchain in healthcare. We would have had an update from another piece of work that we're doing on the remote management of heart failure at home with a GP group, and how they're linking in with the hospitals and managing the patients. And this is all done remotely as well, and how it triggers. And the results from that, the initial findings and results from that have been phenomenal. So we would have various, last 2 to 4 hours. Keep an eye on Twitter and our website. And the next staff is just with the cyber attack. We were due to have one in June this month, but realistically, we're probably looking at September now. So that's it. Yeah.
Great. Okay. Look, we're out of time, but I'm just going to one question there from Tom. Again, it was on the cyber attack. Do you think that will speed up long-term the implementation of moving everything online?
I hope so. That's as much as I could say. I think it definitely is the way to go. There's no doubt about that. And our experience of the last, with COVID, and just as we were thought we were getting out of COVID, that this came along and kicked us in the behind. I think, yes, I think it will. I think so. Yeah.
Great. And last question, Maria, are these new systems being built with data interoperability in mind, or will they all end up siloed? No, data interoperability. And we already have, research and people with AI backgrounds already looking at the data. We have a formal evaluation of the implementation of Respire Sense. We've commissioned an academic from UCG to look at this. We have a postdoc actually working with us, Michael Broderick from Trinity, who's also beginning to look at Respire Sense data as well. So not at all, no, it won't sit there. This will go. Evidence like the Beaumont paper was
last year. It was published in the BMJ. There's the research from Cork will also hopefully will be submitted for publication. There's multiple pieces of nursing work going on around. We have a nurse down in the West who's actually doing a PhD and is very keen on what we do. So no, absolutely not. No. This is all teach, all learn, I suppose, is our approach. Dennis, to be honest with you.
Okay, fantastic. Yeah. Yes, look, we're out of time, but okay. I think we could spend hours at this, you can see the level of questions. And look, thanks so much for a really enlightening presentation and for fielding all the questions. Looking again, compliments to you and the HSE for all the great work you're doing. I think people should know that you, and I think it came through on the presentation, but you have yourself trained in design thinking, and it's great to have somebody who understands and believes in that approach, working at the cutting edge in the HSE. So thanks, Des, and best of luck. And look, to our audience, a couple of notices. We have a book draw, I hope, at this stage. And here we go. We mentioned that we would have 10 books. There's 5 books there from Barry O'Reilly's book on there, and Barry spoke at our annual conference a couple of years ago. And then we have 5 books from Aidan McCullen's book, Undisruptible. So they're the names, so they're the lucky people. There will be another draw for 10 more books at the end of today's session. So 2 more notices from me. 1:15 in just under 10 minutes, or just over 10 minutes time, we have our networking. So this worked really well yesterday. It's a rapid fire networking. 1:15, you can get the link in the agenda page. So I would urge you to go and join in with that and meet some new people. Also, please do visit our exhibitors when you have a chance over lunch on the platform. And our next talk is at 2 o'clock, and we'll be back with the IRTG member forum, where we'll have 2 companies, McKesson and Irish Life, sharing their experiences of using a design thinking approach. So grab a bite to eat, network, and we'll see you back at 2 o'clock. Thank you.